Thank you very much, Hugh Jamar. It was a pleasure, and thank you very much for the committee for this invitation. It's an honor for me to be there. Specifically, this is a topic, as Dr. Jamar suggested, I've been interested in this for a long time, and it's basically one of my passions. And as the previous speaker mentioned, the more of these procedures we do, the more we understand how much we don't know and how much more we need to learn so that we can provide the best treatment for the patient. These are my following disclosures. So the learning objectives is basically to find out exactly what's the team-based. I think this team-based approach to coronary revascularization is extremely critical. The recommendations behind it, and Dr. Jamar already touched about the hybrid approach. I'm going to touch about the rationale for hybrid approach, why I think that would be potentially the future of what coronary revascularization is going. So my talk is the state-of-art surgical revascularization. So I looked up in the dictionary, what is state-of-art? Well, the definition of state-of-art is the highest level of general development as of a device, technique, or a scientific field achieved at a particular time. Or another definition is the latest and the most sophisticated advanced stage of a technology, art, or science. So if you go historically, conventional coronary artery bypass grafting surgery, which I'm not going to really go into, has evolved quite significantly. We now know probably the best bypass that we give to our patients is utilizing multi-arterial graft that lasts the longest, specifically the internal thoracic arteries. If you look at historically in the literature dating back to 1986, there's numerous papers out from the Cleveland Clinic has shown the influence on survival when the internal mammary artery has been utilized, whether it's a single internal mammary artery, the left one, or bilateral internal thoracic artery. Again, all have shown that it improves survival and definitely is probably the best modality of revascularization for the left anterior descending coronary artery. Again, this is another one from the Cleveland Clinic showing that how effective this particular graft has been. And if you look at the most recent report from the Mayo Clinic looking at revascularization using either bilateral multi-arterial revascularization versus just a lima with the saphenous vein graft, you see that survival definitely over 15 years is less when a lima and a saphenous vein graft is utilized compared to when multi-arterial, specifically bilateral internal thoracic arteries are utilized. Also, if you go at some other literature out there looking at non-LAD coronary arteries, specifically the ones that have got a low-grade stenosis, less than 80%, they definitely have a lower patency rate when they compare them to the internal mammary artery, specifically the saphenous vein graft, or even specifically the radial artery, which is the next arterial graft that usually is utilized. But if you look at the real world, specifically the Syntax trial has been quoted numerous numbers of times, that's not what's happening in the near world. In the Syntax trial, if you look at the number of arterial grafting that was utilized, out of 2.8 plus or minus 0.7 grafts that were used per patient, only 27% were bilateral lima and rima, and only 19% had a complete arterial revascularization. So in the real world, despite us knowing that multi-arterial revascularization is better, it's not really being performed. That's what it is, even if you look at the Society of Thoracic Surgeons database. So therefore, if you go back and say, well, if coronary revascularization historically has been compartmentalized in either a percutaneous treatment or surgical treatment, I think as advancement has occurred in technology and surgical techniques along with the stent technology continues to improve, I think it's very critical for us to go back and see there should be alternative methods in providing care to patients with coronary artery disease. However, as we know, and a lot of people have alluded about the problems we have with the cost associated with that, I think we have to look at the challenges we have in healthcare. Healthcare system is significantly undergoing a revolution, specifically in Canada. I come from Ontario. We're under the scrutiny of exactly the number of cases we can do, number of impellas, number of TAVIs. All these are very critical. So funds are reduced. Healthcare and research is all very critically being appraised. We have a large middle population that are the basic baby boomers are going to become significantly ill and requiring this treatment. There's competition for patients. And there's also this huge technology explosion. And some of these technologies are uncertain to what extent is it going to help us. So hospital administrators, they look for the bottom line, which is budget driven. You got to stay within your budget. Technology development is also more restrictive. For example, TAVI technology in Ontario, most hospitals are within a budget. You cannot go beyond that number that was given to you. Also, the informatics is growing, database. We have got worldwide communication where we can basically compare data and also be able to basically communicate with our colleague to provide the best care. In addition, patient acuity has increased. People have got much significant more comorbidity. The last patient in the live case has an extremely high-risk situation. So comorbidities, high-risk patients have increased the possibility of also medical legal kind of situations. So hence we have to be also very careful about the type of treatment we do with patients, specifically since the society has become a blame-seeking society. So under government scrutiny being increased, basically you pay for performance, changing the funding pattern, all these, and complete patient confidentiality has definitely made us to have better databases so we can provide definitely that our outcome is improving. Specifically now in Ontario, it's become a mandate that we should become part of the Society of Thoracic Surgeon database, and that will again further provide exactly the type of data we have. So surgical intervention learning curves are now becoming less acceptable. That's why you have to basically have better outcomes, and if you want to try to basically get a new technology brought in, the learning curve has to be relatively short, cannot be too long. And in most importantly, patients basically demand new technology, and they basically would like the less invasive intervention. This is, for example, if you look here, the patient's being operated on, and the surgeon goes up and says, "Would you please refrain from texting while I'm operating?" So patients these days are extremely basically aware of what technology is out there. Dr. Cosgrove, who now the CEO of Cleveland Clinic, in his presidential address in 2000 at the Association of Thoracic Surgeons meeting, had something called about innovative is imperative. In his speech, he said, "We must think anew and act anew in clinical practice, education, research, healthcare delivery. At no time in human history has there been the potential been greater for translating biological knowledge and technical capabilities into powerful tools for preventing and treating disease." In addition, Dr. Guyton from Emory University, in his presidential address at the Society of Thoracic in 2004, said, "Cardiac surgery will not disappear, but it will change. We must consider innovation because innovation equals survival. Surgeons who do not innovate will not survive because referrals will shift to those state-of-the-art practitioners who are seen as innovators. We must remain patient-centered and evaluate and focus on new technologies or procedures that offer the most patient benefit." These particular quotes are extremely critical, specifically this day and age, when it comes in deciding what type of treatment is best for our patients. Dr. Michael DeBakey, who died at the age of 99, when he was 97 years old, even him was interested in looking at new technology. He's with Dr. Chitwood, who one of pioneers of robotic surgery, and he's checking out the Da Vinci robot at the age of 97 to see what possibilities could be possible. So looking for innovative technologies never ends, no matter what age you are. So what's the future of cardiac intervention when it comes to specifically revascularization? Well, I believe it's a multidisciplinary team approach, collaboration, to provide the best treatment for patients with heart disease. This will be done most likely in state-of-the-art hybrid operating theaters with computer-assisted procedures. The robotic technology Dr. Hugh Giambardo's discussed, that's just the early, very first generation of anything that's out there. The patent of this particular robot is going to expire this coming end of this June. There's going to be an explosion of different technologies out there that will provide us with computer-assisted procedures. I think image guidance is extremely critical for us to provide the best treatment, and modification of cardiopulmonary bypass. That's probably the machine that we use, that we try to avoid sometimes in revascularization. I think will be modified to provide better patient care, specifically in high-risk individuals. So we've been working in silos where PCI is done in one entity and CABG is done with another entity. I think we have to look beyond that, and we have to try to say the future of coronary vascularization, the adoption of disruptive technology by the heart team so that we can work under one umbrella and to modify the technology to best fit the vision of what the heart team is. So at London Health Sciences Centre, we believe that team approach to coronary vascularization involves all these disciplines of medicine: anesthesia, cardiac surgery, cardiology, radiology, nursing, clinical perfusion, and also engineers that help us with the computer-assisted procedures. This is our heart team in the hybrid operating theater, and for me, the day that I have a heart team approach procedure is a day that's basically most, you can say, preferential for me because I can work with a group of individuals that believe in the same thing. So image guidance is extremely important. the heart team preoperative workup prior to any type of procedure with the TEEs, CT scans, MRIs, cardiac catheterization intraoperatively, or all these other guidance that was done on the previous presentation is extremely critical for us to find what's the best modality of treatment. This is what a definition of a CAT scan is. My chief diagnostic tool is a CAT scan. You run across in front of a CAT. If you escape, you're probably healthy. If you don't, you're probably sick. So CAT scans have been extremely, I think, critical in giving us the exact type of, I think, modality for revascularization, whether this can be done less invasively or not. CAT scans have been able to tell us exactly the coronary anatomy, how the vessels are. There were some questions about what are some contraindications in performing minimally invasive surgery. Well, a buried left anterogen coronary artery that's intramyocardial, intraadipose would be a definite contraindication. And in our series, most of the conversions that occurred were because these vessels were buried. So with the help of my radiology colleagues, we routinely perform these basically cardiac-gated, high-definition CT scans to assess exactly where the coronary arteries are so we know exactly where to perform our anastomoses. So to define what's hybrid revascularization is basically surgical revascularization of the left anterior coronary artery using less invasive technique, followed by PCI of the remaining vessel, which is the non-LAD territories. These can be done either simultaneously or in a staged procedure. The very first literature out for hybrid revascularization was done by the group from England, along with Dr. Calafiori's group in 1996. They did 6 patients. From the 6 patients, 4 were done staged, 2 were done simultaneously. The 2 that were done simultaneously was not at all found to be successful because of the bleeding complications they had. So what has happened out there is because of the lack of randomized trial, RCT specifically, we haven't been able to identify what is exactly the target group of patients that benefit from hybrid coronary revascularization. Hence, we have not been able to basically promote this. If you go look at the registry for adult cardiac surgery in the database of the Society of Thoracic Surgery between July 2011 and March 2013, hybrid revascularization was only 0.48%. That's 950 patients out of a total of 198,622 CABGs that were performed basically in North America. So in the American College of Cardiology and the American Heart Association guidelines for hybrid revascularization says primary purpose of performing hybrid revascularization is to decrease the morbidity rate of a traditional CABG in high-risk patients. The European Cardiovascular Society has got also guidelines, and they've got Class 2B recommendation for specific patient subsets and only at experienced centers. Also, the Canadian Cardiovascular Society, their position statement on revascularization using hybrid technology shows that combines the advantage of the lead to the LAD, and studies has demonstrated safety and effectiveness, but randomized trials again are lacking. The Class 2E evidence is hybrid revascularization is reasonable. This is level B evidence if its limitation to traditional CABG, such as heavily calcified aorta or poor target vessels for CABG, but those vessels are amenable to PCI. Also, another one is lack of suitable graft conduits, unfavorable LAD territory for PCI, such as excessive tortuosity or chronic total occlusion. Class 3B evidence from the Canadian Cardiovascular Society is maybe a reasonable alternative to multi-vessel PCR or CABG in an attempt to improve again the overall risk to benefit patient ratio. So there's been a slow growth, and as more and more literature is basically out there regarding showing it, then we'll be able to say that this technology can potentially be improved. So the rationale is, as I said again, in the real world, we still continue to use saphenous vein grafts, and there's the attrition of the saphenous vein graft that is a problem that has resulted not best results. Specifically, if you look again at the results of the drug-eluting stents versus saphenous vein graft, the drug-eluting stents have been performed much better. You can see that 10 to 30% of saphenous vein grafts fail in 1 year, 50% occluded at 10 years. But if you look at the results of drug-eluting stents, and stent technology, as a previous speaker said, has continued to improve, stent thrombosis is reducing and restenosis is reducing. In addition, also to make sure that we do complete revascularization, this is from a Journal of American Cardiology saying that in the PCI, again, the chances of basically having MACE with having incomplete revascularization is significantly higher if you've got incomplete revascularization, and in CABG is the same. So by combining these modalities, I think we can achieve complete revascularization in a much better way. If you look at the syntax trial, again, a 15-month angiographic follow-up in the cohort with left main disease, again, if you look at the group of patients with occluded grafts versus, again, greater than 50% stenosis, is not that different. Again, also symptomatic graft occlusion versus stent thrombosis, again, from the TAXIS trial was not that much different. So the evidence thus far that's out there is, number one, there's not that many, there's only probably one randomized control trial that I will basically get on, but most of them are basically either review of literature based on meta-analysis or comparing it by looking at cohort of patients, comparing them that has undergone CABG. This particular group are very, very well quoted in the literature for having hybrid revascularization as one of their methods. What they did is they took the group with hybrid revascularization and they basically went ahead and did a propensity score matching with similar group from the Society of Thoracic Surgery database, and they looked and compared them. When they compared them, they found really no difference in terms of the characteristics such as basically composite of death, MI, or stroke. The difference they found was in bleeding, and basically the rate of blood transfusion was significantly less for people that underwent hybrid revascularization, and reduced length of stay in the hospital, both in the ICU and overall in the length of in the hospital. So their conclusion was the hybrid revascularization decreases morbidity, chest tube drainage, blood transfusions, and decreased length of stay in the hospital. Another meta-analysis from another group showed a very similar thing, found no significant difference in the outcomes such as death, MI, and stroke, and definitely improvement overall in the length of stay in the hospital and also transfusions. And definitely faster recovery. This group, again, did another review of the literature looking at hybrid revascularization, the Dr. Colombo's group along with Dr. Maesano's group, and they found some interesting things when they looked at the literature. When they looked at people with low syntax, moderate syntax, and high syntax score, and also low Euro scores, and also medium and high Euro scores, they discovered that the patients that had the least amount of MACE afterwards were the ones in the hybrid group that underwent the procedure, specifically in the high-risk group that had a high Euro score and a high also syntax score. And the two particular ones that they looked at was the two studies that I just quoted earlier, and they looked at two things. One was all-cause mortality and any revascularization within 3 years. As you can see, in the group that underwent hybrid revascularization, there was no difference between all-cause mortality. However, it favored hybrid revascularization, but in any revascularization, it favored the CABG group. There was most recently in 2016, there was one-stop hybrid revascularization versus off-pump bypass in patients with diabetes. Again, this group found there was no significant difference in the particular two groups, and therefore in the hybrid groups, therefore, even in diabetics, because of the fact that you're providing an anterior descending coronary graft with a LITA, definitely is as good as potentially having done regular bypass operation. This is the only randomized trial, was done from Poland. They looked at 200 patients. Each group divided. The patients had lesions that were amenable both to PCI, all of them, and also to stenting, and also to CABG. And they randomized 1-to-1 with the hybrid group 98 patient, mid-cap group having 102 patients. And the groups were very similar in terms of the syntax score and other demographics. What they discovered, again, no difference in terms of blood transfusion, MI, renal failure, stroke, and death. And the primary endpoint, again, in terms of the death exam was completely no different. So this group, again, quoted that the MACE even at 12 months was not any different. Hence, their experience was that there's no difference even in a randomized trial. At our institution, we either do simultaneous or stage based on the decision of the heart team. There's discussion made between both the cardiologist and the cardiac surgeon, and then based on what the patient is, we decide whether the patient should be done in stage or simultaneously. So since 2004, we've done 169 patients. Of these, 122 were single, 47 were two-stage. And if again, look, even if in our volume, that's less than 2% our PCI volume, and less than 2% of our basically CABG volume. So what we do first is we do the surgical procedure first in a combined approach. The room is reset, and then the LITA is checked, make sure the graft is patent. Then PCI is performed with Plavix that's given via the NG tube. And then two-stage, of course, the patient is taken the next day to the cath lab where the regular procedure is performed. So this is our hybrid operating theater where we're getting changed the room to have on-the-go PCI. Now this is the algorithm we use for anticoagulation when we do simultaneously. Patients remain on aspirin. We utilize bivalirudin both for the surgical revascularization and for the PCI. Once the LITA is harvested, the bivalirudin is given, is continued on through the surgical revascularization, and then continued on through the PCI, and then clopidogrel is given. There's an overlap between the bivalirudin and the clopidogrel. This is further showing it exactly what happens. The mix is a minimally invasive cardiac surgery when it occurs. That during the 30-minute delay of closure, that's when the LITA is checked, then Plavix is given, bivalirudin is continued, and then device basically closure is done, and then the Plavix continues on, and the bivalirudin is closed off within an hour after the Plavix is given. This is the preoperative coronary anatomy in the lesions that we've done. 13 left main, 139 patients were 2-vessel, 17 were 3-vessel disease. And of course, these are the different territories where patients underwent the PCI. Postoperative complication, the rate of atrial fib is significantly lower compared to regular CABG. We've had 1 patient who had a perioperative MI, 4 patients had bleeding that had been taken back for exploration, and 1 neurological complication only from the series. Average length of stay in the hospital is around 1 day in the ICU, 3 days total. On selected patients, we do what's called the ultra fast track. Thus far, we've done 54 patients where we avoid the ICU completely. They go to the recovery unit. They extend the recovery for 4 hours. Then they go to the regular ward. These patients get discharged home on the 2nd day postoperatively. So thus far, up to 12 years, all these patients are doing well. They're CCS class 0, NYHA function class 1. In terms of the angiography, we follow these patients very carefully. At 6 months, patency rate of the LITA is 94%, and for the stent is 92%. We did a 5-year patency by doing CT angiography on them. The LITA patency has remained at 94%, and the stent patency is also at 92%. We do a long-term follow-up in terms of the overall quality of care, how they're doing in terms of excellent quality of life. Both of the questionnaires have been basically very well. All these patients have got great quality of life. So what's the evidence thus far? Well, even though there's larger RCTs are required, thus far the available data suggests that hybrid revascularization is safe and feasible with short-term results similar to conventional CABG in carefully selected patients with multi-vessel disease. It has the advantage of reducing significant postoperative morbidity, such as sternal complications, infection, neurological complication, and much quicker recovery. The challenges are the requirement of institution to adopt a complex, costly procedure requiring a special equipment, unique expertise, and close collaboration between interventional cardiology and cardiac surgery, when similar survival and morbidity outcomes can be obtained with a well-established, already safe procedure that's available in their hospitals. The strengths of a hybrid revascularization is the evidence improves that the MACE outcomes is much better with the hybrid coronary revascularization, specifically in patients with higher Euro scores and higher syntax scores. And this is a potential target population that would benefit from this complex procedure. The strength also is that in lower to intermediate risk groups, this could be justified since it reduces the length of stay in the hospital and also improves patient satisfaction. The faster return to work in patients with hybrid revascularization is very, very attractive to patients. The challenge again remains that the people that are supporters of regular CABG claim that hybrid revascularization is more expensive as demonstrated by in-hospital cost specific data because there's hidden costs involving construction and maintenance of a hybrid OR. However, hospital administrators and governments may hold a different view, saying that by basically reducing the length of stay in the hospital and avoiding the ICU specifically, you have significant cost savings, and you also improve the work days lost of the patient. So I think hybrid revascularization should be looked as another tool in the box for both the surgeon and the intervention cardiologist to allow them to work together to contribute towards better patient care. So the take-home points are, hybrid team approach has the potential of being, I think, most likely the future of coronary vascularization. Hybrid revascularization is safe and feasible for stable coronary disease, favorable anatomy, intermediate risk, and intermediate syntax scores, preserved or mildly decreased left ventricular function. For high-risk patients, I think is an area that we need to do more research to find out, will this group of patients benefit from this particular approach? So we need more clinical studies, more randomized controlled trials, whether this procedure is definitely as good, specifically in diabetics, that we've already had 1 clinical observation. So in conclusion, technological innovation remains, I think, the insular pathway to new therapy and in de facto risky, uncharted waters. The heart team who seizes this challenge becomes the captains of innovation. Our major risk today, of course, as has been said before, is the cost associated with deploying this new technology for the care of our patients. So patients of today, as mentioned, demand improved operation. They prefer no operation at all. Technology has made the heart team understand what can and must be done by co-opting innovative devices and to work together and develop new methods. Only do a procedure when it's indicated, develop and follow protocols, and I think most importantly, collect data meticulously, analyze it, and self-evaluate whether you're doing things correctly. The heart team must modify operation towards better, wants to obtain better patient basically recovery, pain reduction, improved cosmesis, and better neuroprotection and longevity of the particular procedure. This is a quote from Alexander Graham Bell. When one door closes, another opens. But we so often look at so long and so regretfully upon the closed door that we do not see the doors that are opening above us. I think we have to be open-minded with this, work together, and work towards one thing. This is, again, as I said, my team, that we work together. I'm very, very, very fortunate to be part of this team. And again, I hope that in the future we can continue to have such discussions. Thank you very, very much.